This is to move material back into the blood. And I think if I remember correctly, seeing a question or two about, being able to differentiate between tubular reabsorption, and then the third process is sort of a fine-tuning process, if you will, tubular secretion. And what this is the movement of material, water and dissolved substances, from the filtrate from the blood back into the filtrate. And so, the important thing to be able to differentiate between is, what's the difference between tubular reabsorption and tubular secretion? Tubular reabsorption is, and they occur by both passive and active processes. Some require energy, some don't. Some are concentration gradient driven. But the reabsorption involves the movement of material from the tubules back into the blood. Okay, and then the tubular secretion is the movement of materials from the blood back into the filtrate, and then that will eventually end up in the urine. All right? So we have filtration, reabsorption, and secretion. These are the three processes that are involved in urine formation, in cleaning out our blood, if you will, saving materials that we need, and getting rid of waste products and toxins and things, drugs or whatever we've put into our system that are not normal and they're not needed. Okay, like when you take a pill, you take 500 milligrams of penicillin. All right, gets into your blood, dissolves, absorbed into your blood, passes through your kidneys, and a good percentage of that will end up in the urine. So out of that 500 milligrams, the effective dose that after it goes through the kidneys one time, you may have about 430, and then it goes to the liver where it further gets detoxified because it's a chemical. It's not something that the body recognizes as normal, breaks it down, but you get the point. So this is why, when they do a urine test, whatever you put into your mouth or whatever you put into your blood, because these kids are asking me that all the time. Well, how long does, the active ingredient in marijuana stay in your blood? And I said, well, that all depends, on how much you've done. But whatever you put in there, whatever ends up in the blood will end up in the urine and will show up in the urine. Okay. All right. Blah, blah, blah. Where are we at? It's important, number one, to remember these three processes in urine formation: filtration, reabsorption, and secretion. It's important to remember that we filter about 180 liters a day, and we reabsorb approximately 178 liters per day. And again, these are approximate values depending upon activity. So most of what we filter, the volume anyway, we reabsorb. On average, the average urine output for an average adult, somewhere between 0.75 to, we'll just say 2 liters per day of urine. Now, of course, that can change depending upon your intake and your activity. But on average, we don't pee out 178 liters a day. For Christ's sakes, if we did that, we would be peeing all day long. So most of what we filter, we reabsorb, because the body needs not only the water, but the materials that are pushed out during this filtration process. So if you were to do the math on that, and somebody would ask you, well, how much of the filtered blood do we reabsorb? It's about 99%. 99% of what the kidneys filter gets reabsorbed back into the blood. Okay? Now, it's obviously not as simple as that. I mean, there's a countercurrent mechanism that happens, that occurs with this loop of Henle, or the nephron loop, and it specifically spells out when and what materials will be reabsorbed back into the blood and what materials will end up back in the filtrate. We don't need to really get into that kind of detail. We do need to be aware of these three things. We need to be aware of these facts, that we filter about 180 and we reabsorb about 178, and so the amount of urine, or the amount of filtrate formed, approximately 99% of it is reabsorbed back into the blood. Now, when I talk about the reabsorption of materials like sugar, because we can't live without sugar, we can't live without glucose, there is a threshold what these tubules can reabsorb. Okay, in other words, there's a certain amount that they can reabsorb, and then they can't reabsorb anymore. And then the excess sugar will end up in the urine. Now, if you start seeing sugar in your urine, what are you thinking about?
Diabetes.
Diabetes mellitus, yes. Because your blood sugar's too high. You've squeezed it out in this filtration process, but your tubules are only set up and designed to reabsorb so much, and then the rest of it ends up in the urine. So glycosuria is the classic symptom of diabetes. That means glucose in the urine. Okay, so that's classic for diabetes mellitus. Okay. All right. That's a pretty good snapshot of that stuff anyway. All right. A few other, and there is a table here. Oh, I'm sorry, figure 17.7 on page 529. And it'll just give you this general outline that we just did. All right, starting at the glomerulus, into the glomerular capsule, all right, then into the proximal convoluted tubule, loop of Henle, distal convoluted tubule, collecting duct, minor calyx, major calyx, and then into the pelvis, and then from the pelvis into the ureter, then from the ureter into the urinary bladder. Okay, so just kind of review that real quick. I don't believe I'm going to ask, or you're going to be asked to, define every little piece of it, but just be aware that this tubular reabsorption and this tubular secretion, these processes occur in these peritubular capillaries. Okay? And again, they're designed to conserve what the body needs. All right. Now, there's a couple other points that I need to bring up about some specialized structures in the kidneys, because not only do the kidneys help to concentrate urine and conserve water, but they help to regulate blood pressure. And they also are involved in the release of erythropoietin, which is involved in red blood cell formation. The kidneys are also involved, and I guess I'll go ahead and add that to it, in maintaining, or they help to maintain, not only water balance, but pH balance. balance. And if you remember what the normal blood pH is, do you remember? 7.35.
Okay.
For venous blood to 7.45 for arterial blood. So that's our normal pH. Kidneys are involved in helping to maintain that pH balance by these two processes. You know, they can either secrete hydrogen ions. Here, let me just start getting rid of some of this. And if you remember, or if you don't remember, hydrogen ions, whenever you see a hydrogen ion, you're thinking acid. All right? So if the blood is too acidic, then during these processes of tubular secretion, hydrogen ions can be transported back into the filtrate at that point to help maintain normal pH. Okay. Speaking of that, urine pH varies anywhere from about 5.5 all the way up to 8.0 normally. Okay, and again, that depends on the condition or the pH condition of our blood and our tissue fluids. All right, if we become acidic, if our blood starts to become acidic, one of the things that can happen is the kidneys can excrete more hydrogen ions to bring the blood pH back up to normal. If the blood becomes too alkaline, too basic, then during the process of tubular reabsorption, it can reabsorb more hydrogen ions to sort of balance out the blood pH. Okay? So these kidneys are very important. I mean, you can't live without them. You can live with one, and what will happen, should you happen to lose a kidney, God forbid, but you know, the other kidney will sort of, it'll take on most of the responsibility of the second kidney. It'll work twice as hard, and it may enlarge a bit, but certainly...
Certain people will donate a kidney to a relative or something like that?
And you can carry out a normal life. Now, you may have to make some dietary changes and some activity changes, but certainly you can maintain a normal, so-called normal life with just one kidney, yes. But you can't live without at least one. And when your kidneys fail and they're not working, you have to go and undergo what is known as hemodialysis. All right, and that is where they put, they hook you up. What they'll do, at least in the early stages of hemodialysis, they'll do what's called a shunt. They'll open up a vessel in the arm, two vessels in the arms, and they will hook an artery to a vein. Okay, and you can imagine what would happen when you do that. Arteries are very high pressure, the veins are very low pressure. So when you make that anastomosis or that connection, then that vessel will enlarge and become very visible on the surface of the skin. They do that for ease of access. So you can poke a needle into it and then run your blood volume through a machine, a dialysis machine, which does all of this stuff that we talk about, to maintain the normal constituents of blood and the normal constituents of urine, okay? And again, a lot of that, how often you have to do it and what they have to do during the dialysis process and what kind of dialysate they use and so forth will is dictated by, the degree of kidney failure that you're in.
I had a patient that had to have it Monday, Wednesday, and Friday, and he was in nearly 5 hours every day.
He's in end-stage renal disease, ESRD. And you may see that if you're doing coding, ESRD. That's end-stage renal disease. And I would imagine if he's going 3 times a week, 3 times a week, 5 hours a day, every so often they have to transfuse blood.
Not sure, but I guess so.
But you might, because one of the things that the kidneys do is hematopoiesis. Okay, and so if that part is not working, then they have to transfuse blood to keep up blood volume. Okay? All right, talked a little bit about urine pH. And remember that the kidneys do help to maintain acid-base balance, pH balance, if you will, and red blood cell formation. Okay, there is another, I already said that here. It helps to regulate blood pressure. Let's address that real quick. There is an area in the kidneys called the JGA, and that is for the juxtaglomerular apparatus. All right, and you can kind of take a look and see where that is. It's just where, it's an area near the glomerulus. If you look at, in the walls of the arterioles near their attachment to the glomerulus are large, smooth muscle cells called the juxtaglomerular cells. The point and the important thing to remember about this JGA is these cells, they're sensitive to changes in blood volume. All right, when blood volume goes down, pressure goes down. And so they release an important hormone called renin in response to a decreased blood pressure. Okay, and what that renin does is renin is released into the blood, and the renin will interact with a substance called angiotensin II or angiotensinogen. Sometimes some textbooks will call it angiotensin II. And this is a substance that just normally is circulating in the blood. Okay, so when this renin is released, it interacts with this angiotensinogen and converts it to a substance called angiotensin I. Okay, and that is facilitated by an enzyme. And I'll tell you why I bring this up in a minute. It's facilitated by an enzyme called angiotensin converting enzyme. All right, and I bring that up because you may see in your dealings with medical records certain patients that are on a drug that are called ACE inhibitors. And that ACE is angiotensin converting enzyme. And what this when this renin interacts with angiotensinogen, converts it to angiotensin I, and among other things, angiotensin I is a very powerful vasoconstrictor. In other words, it squeezes down blood vessels to bring up pressure. So when the pressure drops, and that's sensed by these cells in the JGA, the juxtaglomerular apparatus, they will release this hormone. This hormone will interact with this angiotensinogen.
So it's for hypotension instead of hypertension?
Hypotension, yes.
Okay.
All right? And then the angiotensinogen is converted into angiotensin I, which is a very powerful vasoconstrictor. And this angiotensin I also stimulates the release of aldosterone. Now I'm going to poke your memory. Say, where does the aldosterone come from?
I'm sorry, John.
That's all right. It's a mineral corticoid released from the adrenal gland. And what it does is works on these kidney tubules that we've been talking about to reabsorb sodium. And remember, the general rule is wherever the sodium goes, water follows. So the whole point of this is we want to squeeze down the blood vessels to bring up the pressure. We want to reabsorb more sodium and therefore more water to bring up the volume and bring up the pressure. Okay? And so that is sort of the take-home message on this JGA. Now, there are certain people out there with hypertension, with high blood pressure, and you know, when they start to treat high blood pressure, it's a game. They say, well, let's try this, see if it works. If it does, we're good. If it doesn't, then let's try this. Well, in the course of those regimens, they may prescribe one of these ACE inhibitors, these angiotensin converting enzyme inhibitors, okay? To block the action of that enzyme, which will block the formation of angiotensin, okay, so that the blood vessels don't constrict, and so that aldosterone is not released and the blood volume doesn't go up, all in an attempt to keep the blood pressure down. Because you know, the more volume, the more pressure. The smaller the vessel, the higher the pressure. So if you can kind of knock those two things out, you're working toward treating the hypertension. Okay, and like I say, it is a game. They'll say, well, you know, we might start off with a beta blocker. You know, a beta blocker will, depending upon what type of beta blocker, but a beta blocker will ease the smooth muscle in arteries and arterioles primarily, so that they relax a little bit, they get bigger, pressure goes down. And we say, okay, did that work? Ain't working too well, so let's try something else. Then we'll add a beta blocker and we'll add in a hydrochlorothiazide, something that'll is designed to help you produce more urine.
A diuretic.
A diuretic. That's what HCTZ and hydrochlorothiazide is. It's a diuretic, because if you bring the volume down, the pressure goes down. And then you see how that works. And if that doesn't, then there's a variety of things, but these ACE inhibitors are included in that approach to try to bring down blood pressure. Because most hypertension is what they call essential hypertension, which means we don't know what's causing it. So let's try some things and see what works. That's why, when people ask, they say, well, how do I know if I have high blood pressure? I said, well, this is what you do. You set up a routine. You check your blood pressure 3 times a day, the same time every day. When you get up, around noontime and before you go to bed, and you record it. And you do that for a period of time, 2, 3, 4 weeks. Keep a record. And then you look at averages. And you say, well, what's normal for me? Well, at this, at whatever stage of life you are, you'll begin to see a trend. And then the physician will come and say, well, those, that diastolic or that systolic is too high.
They used to say it was your age plus 100.
Yeah,
that was an old.
That was an old calculating tool. Yes, but generally, you don't want your diastolic above 130, and you don't want systolic, and you don't want your diastolic above 90. All right, these are just average sort of numbers. Okay, but again, people ask, what's a normal blood pressure? And the response is, what's normal for you? Yours and mine, we're about the same age, right? Or you're
I'll be 70.
Oh, you got a few years on me. So your normal blood pressure is not the same as mine, yet. I'm getting there, though. Today I feel it. Okay, I bring up the JGA just to introduce and make you aware of this. They call it a renin-angiotensin mechanism, because the renin, the hormone, interacts with angiotensinogen to produce angiotensin 1, which vasoconstricts and stimulates, among other things. Again, the two, what I believe is the important ones, is vasoconstriction and the release of aldosterone. Okay? If we can block that, then that's just one more thing we don't have to worry about with high blood pressure. But if you're in a you've been shot in the abdomen and happened to nick your aorta and you're bleeding out from your aorta, this will definitely kick in, okay, to try to squeeze down and prevent blood loss and keep blood pressure up so you can perfuse your brain and your vital organs. Okay.
So what, how, they'll give you 10 minutes, 15 minutes?
Well, it all depends on the degree of damage, but I mean, it could give you longer than that.
Okay.
Yeah. Now, if you've got a 12 gauge round that went through your aorta, you don't have any time at all. But it's not to say that it won't kick in, because it will. And then once you get to the hospital, if you make it and you're still alive, they'll start infusing drugs that essentially are designed to do the same thing. Squeeze down the blood vessels and bring your blood pressure up. Okay, where are we at? We've been through that. Go through here, and on page 530, just be aware of this little, are you on 5?
I'm 532, I'm sorry.
I go to 530,
yes.
and look at this little calculation down here.
Okay.
And this addresses the final product of these three processes, which are filtration, reabsorption, and secretion, equals the amount of urine that we put out per day. In simple terms, that's what's up. Okay? And again, we filter out about 180, we reabsorb about 178. On average, the average urine output, half or 3/4 of a liter to 1.5 liters, 2 liters a day is normal. Oh, and another thing that you might, because I can tell you, having worked in ICU and CCU, when we monitor urine output very closely, we're looking for a minimum rate of 30 milliliters per hour. Okay? Of urine output. All right, that is a industry, well, at least it was, I'm sure it still is, an industry standard. When you're monitoring a patient and you're very concerned about their urine output, they need to be putting out at least 30 mils an hour. If not, you have to address it.
Because you're pumping in fluids, so if they're not getting rid of it, they're starting to...
Something's happening,
Yeah.
yes. And you're right. It could be indicative of kidney damage, and most times that it is. And there are
Can a
other...
kidney heal, or can a kidney heal?
Sure.
Okay.
Yeah, depending upon what's wrong with it. Like there's a very nasty circumstance called acute glomerulonephritis. And as the name suggests, you know what that itis means. The itis suffix means inflammation of. Okay, and this is not a good situation. This needs to be addressed. You're going to be hospitalized for this. All right, and you've got inflammation going on in the glomerulus, and so some things that you might see are proteinuria. All right, and that is proteins in the urine, because normally proteins are not a normal constituent of urine. Okay, you might see hematuria. What do you think that means?
Blood in the
Blood in the urine, yeah. Glycosuria.
Sugar in the urine.
Yes. Okay. This is usually due, to a bacterial infection. All right. All right. Let's see. Go ahead and filtrate. We talked about the angiotensin mechanism. Okay, now, sodium and water reabsorption, tubular secretion. Heck, we're getting there. All right, just a few things about the bladder. Oh, here kidney stones. People ask about those all the time. What causes them? What are they made of? And what can I do to help prevent the formation of these kidney stones? Well, their formation, for the most part, is...
That's page 540.
Page 540, clinical application 17.1. Yeah. And for the most part, there's a genetic predisposition to forming these things. You know, if your mother or your father or anybody in your immediate family had a tendency to form kidney stones, chance that you may have inherited that same tendency. They're mostly calcium and what does it say about here? Blah blah blah. The tendency to inherit the stones is inherited. They're composed of uric acid. And if you remember, the uric acid comes from the normal metabolism of nucleic acids, like your DNA and your RNA, okay? So it's composed of uric acid, calcium oxalate, calcium phosphate, and magnesium. So uric acid, calcium, and magnesium, all right? And I've been told, though I've never had the pleasure, that if you develop a kidney stone, and if you are fortunate enough to pass it, that is as close as you'll come to the pain of what a woman goes through during labor and delivery. I have seen, you know, monster men being brought to their knees from a kidney stone. Thank the Lord that I haven't had to go through that, but I don't imagine it feels very good. Now, back in the old days, before this lithotripsy was came into being, you know, they used to do things. They used to either open up, you know, slice you open and go in and manually remove it. Then they developed a technique called a basket extraction, where they could go up through your urethra, into your ureters, into your renal pelvis, and they had with a catheter, and then they would turn it, and a little wire basket would open up, and you get the stone in it, and they turn it back and close it, and then try to bring it
Using
through.
ultrasound to visualize?
Well, not ultrasound, but
Not X-ray.
yeah, X-ray. They would use X-ray, and they would use what is the thing that they do?
CT, no.
No, not CT. Fluoroscopy.
Oh.
They do it under fluoro. Yeah. Now they have a procedure, and you might want to make a note of this. It's called lithotripsy. All right, and there's a specialized name for it. It's called, we just called it
Extracorporeal shockwave?
extracorporeal shockwave lithotripsy, yeah. TRIP, not Y. And what they do is, what we would do, because this was just, you know, coming in, becoming more popularized right before I started to get out of the game, but you'd take a patient, you'd sit them into a tub of water, right? And we would not put them under general anesthesia. We would put them on what they call twilight, you know. We'd get them good and stoned because we want them breathing on their own. And then they have an instrument, a wand, if you will, hooked up to a high frequency radio waves, and then they would blast the rock with these high frequency radio waves. They wouldn't, you know, and it's not invasive. You don't have to open up the body to do it.
So you access the kidney from the back?
Yeah, because your kidneys are located retroperitoneal.
Okay, all right.
And you remember most of them, or a lot of them, are protected by your ribs, but part of them, especially on the right side, hangs a little bit lower, and so it's not protected by the ribs. So they use this wand using fluoro, and they can